Welcome to this explainer. If you're prepping for your MRCOG exams, or honestly, if you just want to make sure your clinical practice is totally up to date with the latest evidence, you're in the exact right place. Today, we're bringing together the absolute most critical, actionable updates from the latest ESHRE and NICE guidelines on endometriosis. We've taken these massive, dense guideline documents and boiled them down into a high-yield clinical pathway so you can grasp and, more importantly, retain exactly what you need to know. All right, let's dive right in.
Let's kick things off with a pretty stark number, 8 to 12. Globally, we are looking at a massive diagnostic void averaging 8 to 12 years between the onset of a patient's symptoms and a reliable diagnosis of endometriosis. I mean, just imagine the impact of that delay on someone's quality of life. From an MRCOG perspective, it is absolutely vital to recognize that this delay doesn't just prolong suffering, it actively drives disease progression, central sensitization, and the development of really complex chronic pelvic pain syndromes. As clinicians, closing this unacceptable gap is our primary mandate, and that's exactly what these updated guidelines are designed to help us do.
Here's our game plan for this explainer. We'll be hitting clinical burden and definitions, recognizing signs and symptoms, the diagnostic paradigm shift, general and surgical management, what happens when fertility is the priority, and finally, your key MRCOG takeaways.
Section 1, Clinical Burden and Definitions. Let's quickly establish the scope of this disease and the exact updated terminology your examiners are going to be looking for.
A staggering 190 million women and adolescent girls worldwide are affected by this condition. Endometriosis is definitely not some rare edge case presentation. It is a profound global health burden. And while we generally think of it as a disease of reproductive age, remember for your exams that the clinical consequences, the ongoing pain, and the management challenges can often stick around well into postmenopause. This is especially true when you're factoring in hormone replacement therapies.
Now take a look at this updated consensus definition from the International Working Group. The nuance here is a real game changer. It specifically characterizes the disease by the presence of endometrium-like epithelium and/or stroma, but crucially, it adds this phrase, usually with an associated inflammatory process. This formal recognition of the inflammation is absolutely vital for understanding the pathophysiology and all those systemic, wide-ranging symptoms patients experience that go way beyond just pelvic lesions.
Section 2, Recognizing Signs and Symptoms. What are the baseline clinical presentations that should instantly trigger your suspicion before you even think about imaging or surgery?
You absolutely must recognize the varied presentations of this disease. The cardinal signs are things like dysmenorrhea, deep dyspareunia, dyschezia, and painful rectal bleeding or hematuria. But here is the trick for the MRCOG. Don't just memorize the classic pelvic stuff. You need to be on high alert for cyclical and non-cyclical presentations like shoulder tip pain, which points to diaphragmatic endometriosis, or catamenal pneumothorax, and even just profound, unexplained fatigue. Endometriosis is a systemic mimic, and spotting these peripheral symptoms is a huge part of narrowing that diagnostic gap.
Section 3, the diagnostic paradigm shift. Seriously, if you take away just one thing today, let it be this section. This is a massive, highly testable shift in how we confirm the disease.
So historically, we were all taught that diagnostic laparoscopy was the immediate, undisputed gold standard. Well, ESHRE 2022 officially changed that. Laparoscopy is no longer the primary diagnostic gold standard. The pathway now says you should offer empirical medical treatment first. Think hormonal contraceptives or Progestogens based entirely on the patient's clinical symptoms. Diagnostic laparoscopy is now only recommended if imaging results are negative and empirical treatment has failed, is contraindicated, or just inappropriate. This is a monumental pivot toward non-invasive care, sparing patients unnecessary surgical risks and getting them to symptom relief way faster.
And building on diagnostics, here is a definitive hard no from the NICE guidelines. Do not use serum CA-125 to diagnose endometriosis. Period. It is a classic trap in multiple choice questions. Sure, it might be elevated in advanced disease, but it totally lacks the necessary sensitivity and specificity. It literally has no role in the diagnostic algorithm. Just skip it.
Summarizing these pivotal ESHRE updates, we've got the diagnostic shift we just talked about, but also look at pain treatment. GnRH antagonists are now officially supported as an additional second-line treatment, which is great because it broadens our pharmacological toolkit. Also, pay close attention to the addition of the Endometriosis Fertility Index, or EFI. This index combines historical patient factors with surgical findings, and it's now a formal step to help with shared decision-making regarding the likelihood of a patient achieving pregnancy post-surgery.
Going hand in hand with the move away from immediate diagnostic laparoscopy, the 2024 NICE updates heavily highlight advanced imaging. For suspected deep endometriosis, which could involve the bowel, the bladder, or the ureters, you really need to consider specialist transvaginal ultrasounds or pelvic MRIs. The key word there is specialist. These scans have to be planned and interpreted by someone with highly specialized expertise in gynecological imaging. Plus, this imaging must be completely wrapped up to map out the full extent of the disease before you ever proceed to an operative laparoscopy.
Section 4. General and Surgical Management. Because once your empirical treatment or imaging points to surgery, there are very strict operative protocols to follow.
If you do end up doing a diagnostic laparoscopy, NICE lays out some explicit steps. You've got to do a systematic inspection of the pelvis and thoroughly record both normal and abnormal areas. But here is the major exam pearl. You must consider taking a biopsy. Why? Two big reasons. First, to confirm the diagnosis histologically, though keep in mind a negative result doesn't totally rule it out. Second, and this is absolutely crucial, if you treat an endometrioma without completely excising it, a biopsy is mandatory just to exclude underlying malignancy.
Now, what about definitive surgical management involving a hysterectomy? The core rule here is that just taking out the uterus is not enough. You have to aggressively excise all visible endometriotic lesions at the time of the surgery to prevent symptoms from coming back. On top of that, NICE says this should be done laparoscopically whenever possible. And of course, it requires a really deep, well-documented conversation with your patient about the complicated benefits and risks of concurrent oophorectomy and the hormone replacement therapy they need afterwards.
Section 5. When fertility is priority. How do we pivot when the patient's main goal changes from managing chronic pain to having a baby?
This is the million-dollar question you have to ask in every single consultation, and you need to look out for it in every exam scenario. Navigating these priorities is critical because treating for fertility means taking an entirely different surgical approach than treating strictly for pain. When a baby is the primary goal, you're usually going to need a multidisciplinary team bringing in reproductive endocrinologists and fertility specialists very early in the pathway.
For those fertility cases, NICE gives us clear guidelines to boost the odds of spontaneous conception. If the disease doesn't involve the bowel, bladder, or ureter, offer excision or ablation combined with adhesiolysis. But for endometriomas, the gold standard is a laparoscopic ovarian cystectomy. Watch out for this trap on your exams. This explicitly means surgical excision of the cyst wall, not just draining and ablating it. Both of these interventions are strongly backed by evidence to significantly improve a patient's chances of spontaneous pregnancy.
Section 6. Key MRCOG takeaways. Let's pull all of this together into a high-yield conclusion. This quote directly from NICE Guideline 1.6.1 really says it all. Offer endometriosis treatment according to the woman's symptoms, preferences, and priorities, rather than the stage of the endometriosis. We are actively leaving behind those purely anatomical, stage-based algorithms and fully embracing individualized, patient-centered care. So as you hit the books for your MRCOG exams, or the next time you step onto the ward, I want you to ask yourself this question with every single case you see. Are you treating the stage of the disease, or are you treating the symptoms and priorities of the patient? Keep that question front and center. Remember the massive shift toward empirical treatment and advanced imaging, and you are going to navigate both your exams and your clinic with absolute confidence. Thanks for hanging out with me on this explainer, and keep up the great work.